TopMedTalk. The next speaker is the Chelsia Gillis. He's going to talk about nutritional screening assessment tools for prehab. She's a dietitian, PhD dietitian, working with us at McGill, and she's going to talk about specifically on the nutritional aspect.
Thank you. Can everybody hear me okay? Great. All right. So let's get started with an easy slide. So here we have the surgical stress response. The injury, the trauma, stimulates the release of counter-regulatory hormones and cytokines. And this causes several metabolic changes, but what I'd like to focus on is whole body protein catabolism. The amino acids, that lean tissue is broken down. The amino acids are released into circulation and they're preferentially taken up by the liver. Why? The liver needs to synthesize glucose to maintain energy processes. The liver needs to synthesize proteins involved in the immune response and healing. So essentially, the skeletal tissue is sacrificed to fuel that important role of the liver. But whether this catabolic stress response is critical or not really depends on the patient. If you have a patient with this low muscle mass, when they're hit with this catabolic stress response, they're going to deteriorate their already compromised reserve. They're at risk of increased morbidity and functional dependence. So we need to identify these people who are at risk. Who is malnourished in this picture? Any guess? The answer is, I don't know. Because you can't look at someone and identify if they're malnourished or not. You have to have a screening tool because anyone can be malnourished if the food that they eat does not meet their needs. And you cannot tell by looking at someone. And I think that this abdominal CT series really illustrates this quite well. In all three of these pictures, you have patients with an identical skeletal muscle index. So that's normalized to height. But they would present to you looking very differently. You have a patient with a BMI of 15 all the way to a BMI of 40. But all three of these patients would deteriorate their already compromised reserves when hit with that surgical stress response. So you need a system in place to identify these patients. You can't just look at them and know they're malnourished. And this case cross-sectional study illustrates this point quite well, I think. Among 313 patients who were receiving cancer treatment, the oncologist misclassified the severity of malnutrition in 43% of the cases. Why? Because they're looking at the patients and trying to identify if they're malnourished or not. This is not a good strategy. And now I'm going to show you some data from our preoperative clinic. So it's not the prehab clinic, but our preoperative clinic at the MUHC, at McGill University Health Center. And it's somewhat distressing. Out of 519 oncology patients who came to this preoperative clinic, which is about a week or two before their operation, about a third of them were at nutrition risk. 55% were actually referred to a dietitian. And we thought that, let's look at the length of stay of these patients. You could clearly see that the patients who were at nutrition risk had a longer length of hospital stay, and the more nutritionally deteriorated they were, the longer their hospital stay, almost like a dose response. But what we found distressing is that the patients who saw the dietitian actually were in hospital longer. So why is this? So we had to think about it. And these patients were more obviously malnourished. So they had a severe malnutrition because you could eyeball it. So these 55% who saw the dietitian, it was more obvious. That's why they went to see the dietitian. They were more comorbid. And when is this appointment? About 1 week before their surgery. One appointment with a dietitian 1 week before the surgery. How is that going? There's not enough time and not enough effort put in to optimize these patients. Our data is actually very similar to this data in Australia. 60% of these patients were referred to a dietitian. And what they found was key is that you need 3 appointments at least with the dietitian to be able to reduce surgical complications. So I think this really illustrates the value of having the dietitian in the preoperative clinic. So you need a system in place. You can't look at people to know if they're malnourished. You have to screen them. Anyone who screens positive is then assessed by a dietitian and then treated based on a risk stratified strategy. So the most malnourished patients receive the most effort. They're the ones who need to be seen at least 3 times before their surgery. So I keep talking about malnutrition, but I haven't really defined it yet. What is it? There's no consensus on the definition for malnutrition, but if you look at all of these definitions, I've underlined the commonalities. So it's an unbalanced nutritional state resulting from poor food intake and or disease, and it diminishes body mass, body composition, and function. Now, importantly, if you want to identify somebody who has malnutrition, you need to identify an etiology for that malnutrition and a phenotype. So if you think about it, if you have a patient who's eating well for their needs, they're going to maintain their weight. Now you have a patient who's not eating well for their needs, they're going to lose weight, that's the phenotype, they're going to lose muscle mass, they're going to lose muscle function. Now some patients kind of get confused, and even clinicians get confused, because the patients will say, I'm eating the exact same way, but now they have this disease burden, so their needs are elevated. And if their needs are elevated and they've not met this new demand, they're going to lose weight unintentionally. They're going to lose muscle mass and muscle function. So that's the definition for malnutrition. This is the Canadian Nutrition Screening Tool. Very simple screening tool. It says Canadian, but you can use it anywhere. 2 questions. Have you lost weight in the past 6 months without trying? That's the phenotype. And have you been eating less than usual for more than a week? That's the etiology. Importantly, how do you interpret this? At risk of malnutrition. You don't diagnose someone with a screening tool. They're at risk of malnutrition. These people need to be assessed and diagnosed to determine if they're actually malnourished. Tons of valid screening tools exist. Tons. There is not actually a surgery-specific screening tool. This is something that I'm working on developing. I'm a grad student working on this right now. But there are tons of valid screening tools that you can choose from. So how do you select one? Think about your local factors. What is your pool of malnutrition? Do you have a lot of patients who are malnourished? Is there a tool that's valid for your specific patient population? What's the sensitivity and specificity of that tool? Is it acceptable for what you're doing? What resources do you have available? Is there a dietitian to assess the patients who have been screened? And who needs to complete it? Sometimes the patient can complete it themselves. Sometimes you need a nurse to complete it. So think of all these local factors. We use the CNST, the Canadian Nutrition Screening Tool, and you can see that this tool has a 73% sensitivity in medical and surgical inpatients. What does this mean? This means that we're able to identify 73% of the malnourished patients correctly, but a good chunk of them remain undetected. There are no perfect screening tools. We don't have the resources for every single patient to see a dietitian, so we accept that some patients will fall through the cracks to use our resources responsibly. What is specificity? The CNST has an 85% specificity. So this means that it's correctly identifying those without malnutrition 85% of the time. If you don't have a lot of resources, the dietitian resources, I recommend that you choose a highly specific tool. But if you do have a lot of resources, go for a highly sensitive tool. So what we did to increase the sensitivity of this tool, and we accepted a lower specificity because we have the resources, is those 2 questions. Have you lost weight in the past 6 months without trying? And are you eating less than usual? You're supposed to answer yes to both of those to see a dietitian to screen positive. We take them if they said yes to either one. So we've increased the sensitivity of that tool, but that means our dietitian, Jade, she now has to see more patients who wouldn't be malnourished and assess them. But we've accepted that. This is another really great tool. And as Mike pointed out at the beginning, we're all screening and assessing people differently. If I had to recommend one, this is the one that I would recommend for screening. It's the short form PGSGA. The patient fills it out themselves, but you do need somebody then to score it. So the scoring part about the weight, it doesn't take long, but you have to identify how much weight they've lost and how severe that is. So it takes a little bit more time and a little bit more resources, but this is the tool I recommend for screening. The front page is the screen and the back page is the nutrition assessment. So you've already completed some of the work for the dietitian who then needs to assess the patient as well. Now, a cut point greater than 4 is what's usually used. 4 or greater is usually used for this screen. Now, once the patients have been screened, the dietitian then needs to do a comprehensive nutrition assessment. And this includes a lot of different things. You have to look at what the patient eats, what are their supplemental use, look at their blood work. Do they have high hemoglobin A1C? Do you need to work with them with their blood sugars? Do they have elevated CRP? Do they have too much inflammation that you want to attenuate so that they can use? We have better nutrient utilization. So there's a lot of things that the dietitian then needs to do. But the first part, the screen, is really, really important so that you can funnel these patients in and use your resources responsibly. Oops, I forgot about some of my animations. So here's a summary of things to consider. What tool do I recommend? This PGSJ short form. It's just 4 questions, and someone needs to screen it to score it at the end. It's completed by the patient on their own, but then the health professional scores it. It should be conducted at least 2 weeks, but even that's not a ton of time. If you only have 2 weeks with a malnourished patient, you need really, really, really strict, intense nutrition support. If you have 4 to 6 weeks with these patients, you can optimize them. You have enough time to optimize them, and you don't have to go straight to enteral or parenteral nutrition. Preferably, it should be done at the first surgical visit. You need a lot of time, so if you can do it right at the surgical visit, you have this time to optimize. And if you have the electronic medical record, it's so much easier. They're screened, and then it's flagged. The dietitian gets that notification and can schedule that patient right away. That's the pathway that I recommend. But a couple considerations. When you screen your patients, are you getting the truth? Malnutrition is something that's very stigmatized. And we started to interview patients to understand what they thought of this, being screened for malnutrition before surgery. What does malnutrition mean? They don't want to admit that they have problems. They're worried that it will delay their surgery, or their surgery will get canceled, or they're afraid of what does this mean? If I'm a woman, especially if I'm a woman and I can't take care of myself or my family, what does that mean for me? What does that say about me? So we have to really use a good script with these patients. We have to make sure that we take the blame away when we're introducing these screening tools. Anyone can become malnourished, and it's not necessarily your fault, right? Your body's needs have changed and your body didn't let you know. So now you might have been eating really well, but it doesn't work for your body's new needs. And so that language of taking away the blame is really helpful to get the truth. We had patients who we were screening by telephone who would say, no, everything's fine. And then in person, once they trust the clinic, we're then admitting that they did have these problems. So really, really important that you consider your script when you screen people. And then finally, malnutrition is not the same as sarcopenia. So if you also want to optimize people with low muscle mass, you need a separate tool. And there is overlap between malnutrition risk and sarcopenia. It's in that definition of malnutrition. Eventually, body mass, body composition, and function declines. There's overlap, but they're not the same thing. So if you want to identify these patients with low muscle mass or low muscle quality, you need an entirely separate tool. In this study, this is colorectal cancer patients. 1/3 of the patients had poor muscle quantity or quality, not detected with a malnutrition screening tool, because that's malnutrition and sarcopenia, 2 separate things. All right, so here are my key points. Have a really good script to introduce your screening tools because of that stigma of malnutrition. There are many valid nutrition screening tools, so think of your local context and figure out which one works for you. But if we all want to start using the same tool and reporting the same outcomes, I recommend the PGSJ short form. That's the screening tool. And then the back of the page is the assessment that the dietitian completes. So the PGSJ short form and then full tool to get our screen and assessment. You need plenty of time to intervene. Your severely malnourished patients need to be seen at least 3 times by a dietitian. So make sure you screen early so you have time to intervene. And if the patient screens positive, they definitely need to be assessed by a dietitian. And then finally, if you want to identify people with low muscle quantity or quality, there are different tools. So for instance, you can have a bioelectrical impedance, identify their fat-free mass. You can have CT scans, like I showed you at the beginning, and identify their skeletal muscle index or skeletal muscle quality. You can also use the SART-CAF. That's a screening tool that the patient completes a couple questions and you measure their calf circumference. And that's it. Thank you very much for your attention.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.